Good evening, everyone. It gives me immense pleasure to welcome you all to this CME, which is being organized by the NIGF Jammu Chapter in association with the Academic Wing of the NIGF, highlighting two important topics pertaining to the maternal health. So, we'll be talking about the antenatal care and the ultrasounds in pregnancy today. It is indeed a matter of honor that stalwarts like Dr. Manju Marma ma'am, Dr. Sudha Sharma ma'am, Dr. Ruby Bhatia ma'am, Dr. Mala Srivastav ma'am, Dr. Meeta ma'am are amongst us and have joined us today for this important event. I think Dr. Sharda Jain ma'am is not here and Dr. Ragini ma'am is also not here. So I would kindly request Manju ma'am to address the gathering and give us the message and talk about what we are going to talk about today. Thank you, ma'am.
Thank you, Herlin. And सबसे पहले तो मैं सबको प्रणाम करना चाहूंगी because we would like I would definitely like to thank everyone who has joined, and especially the just to name a few, because Sudha ji is there, Mala is there, Dr. Ruby is there, and all the members of the Jammu and Kashmir chapter. Now, this wing has been created just to create an awareness. We all know the subject, but we just would like to emphasize what are the important points as far as the anemia and how to look after a pregnant woman. And therefore, this is being this topic was given to Jammu and Kashmir, and I'm really thankful to Meeta and especially Harleen. She has done a lot to just organize this meeting, and just not to interfere being between you and the speaker, I would definitely like to hand over the mic again to Harleen to proceed the further proceedings.
Thank you so much, ma'am. Okay. So now for the first session that we are going to have, we are having Dr. Dinesh Kumar sir, who will be the speaker for this first session. And the topic for the first session is antenatal care, the inverted pyramid approach. For this, we are having our chairpersons amongst us. We have Dr. Parik Rana ma'am. Ma'am is Associate Professor. Good evening, ma'am. At SGS Hospital, Government Medical College, Jammu. Ma'am is co-chairperson of the Cancer Mukt Bharat Mission and also the chairperson FOXY Fertility Committee 2026-2028. We also have amongst us Dr. Renu Sharma ma'am. Ma'am is Associate Professor, AIMS Jammu, and Dr. Bharti Maheshwari ma'am, who's Professor and Head at Muzaffarnagar Medical College. I think ma'am will be joining shortly. And the expert for the session is Dr. Navneet Kaur ma'am. So before I hand over to Dr. Dinesh for the session, just a brief CV. So sir is MD Gynecology, FICOG, FMAS, and sir is working as consultant at Government Medical College, Udhampur. Sir, we welcome you, and I hand over the mic to you to talk about this very important topic of antenatal care and the newer approach, that is the inverted pyramid approach. So let's see what's in this.
So now you can share the screen.
First of all, respected NIGF chairpersons and respected chairpersons of this session, and my seniors and my colleagues. I take this opportunity to thank everybody for giving me an opportunity to speak on this platform. And today's topic, which was given to me, was antenatal care, the inverted pyramid approach. As we know, as per the traditional antenatal care model, we used to screen. We used to have a little emphasis on the uh, risk stratification, and majority of the things which developed during the second and third trimester, we used to come across the complications. We detect and then we treat at that
This
very
meeting is being recorded.
and the approach is reactive rather than the predictive.
सर पीपीटी विजिबल नहीं है सर.
आपका स्लाइड शेयर नहीं हो रहा. दिनेश जी हेल्प कर दो.
Ma'am, I'm trying to share the screen.
Full screen now.
Right, sir?
Yeah.
Is it open?
It has not become full screen.
It's visible now. It's visible.
Sir, please click on the slideshow.
Hmm.
Hello everyone.
Hel-
Hello, hello.
Namaskar, ma'am.
Yes.
Dr. Dinesh, you can go to the slideshow, which is on the
Yeah,
top of
the
the
corner,
bar.
right of a corner.
Sir, accept the request, sir.
Oh,
सर एक सेकंड सर मुझे
हेल्प
करने दो.
करो. Yeah. Click here. The fourth square, you are there, or I think.
Is it okay, ma'am?
एक सेकंड से यहाँ से स्टार्ट कर रहे हैं. स्टार्ट स्लाइड शो. जस्ट क्लिक ऑन द स्लाइड शो बटन.
Yeah, side show, just click there.
सर आप पीपीटी मुझे भेज दीजिए सर, मुझे व्हाट्सएप पे.
डॉक्टर दिनेश, आप पहले से
ठीक है,
उस पे हैं, आप बस क्लिक कर लो उस पे.
1, 2, 3, 4. There's an orange column below which is written slideshow. On the left side.
सर आप मुझे पीपीटी मेल कर सकते हैं या भेज सकते हैं क्या? हम यहाँ से डिस्प्ले कर देंगे फिर.
इट विल बी वेरी इजी. ये दिखाई दे रहा, मुझको दिखाई दे रहा है स्लाइड शो. बस उस पे जाके क्लिक करना है. ऊपर जो बने हुए हैं आइकन्स, उसी में देखिए डॉक्टर साहब. एक रेडियो जैसा बना है, फिर उसके बाद एक स्क्वायर में 4 हैं, फिर एक स्क्वायर में 2 हैं, और उसके बाद वाला है ये स्लाइड शो.
सिस्टम हैंग कर रहा है शायद.
हाँ,
हाँ हाँ, ये यहीं क्लिक
हाँ,
कर
यस यस, हाँ, या कर लो।
हाँ
तो स्लाइड शो पे था अभी।
हाँ, यहाँ ये आगे
It is
और आगे
इंसर्ट
बढ़िए, ऊपर वाली लाइन में।
डिजाइन,
या
हाँ यहाँ क्लिक करो। अब नीचे जाओ,
अभी था वो वहीं पे।
फ्रॉम बिगनिंग कर लो। नहीं नहीं
या
नहीं, इसको रहने दो। अब नीचे वाली लाइन में फ्रॉम बिगनिंग और करंट स्लाइड। इसके पहले, हाँ एक और आगे, एक और पहले, ये फ्रॉम बिगनिंग वाले पे जाओ। हाँ अब इसको क्लिक कर दो यहाँ।
डॉक्टर साहब उसके ऊपर वाली लाइन में जाइए।
नहीं, ये हो रहा है, कुछ प्रॉब्लम हो रहा है सिस्टम की तरफ से। यहाँ वहां से हो जा रहा है, फिर कैंसिल हो जाएगा। मैम आप सर, आप ऐसे ही स्टार्ट करिए सर। टाइम
हाँ, आज से ही चलने देखा, टाइम करना फास्ट।
चल स्टार्ट करते हैं सर।
या
So, as per the conventional pyramid model, there was limited early risk assessment,
डॉक्टर
and
आपका 2 2 मिनट स्टार्ट सर।
there was limited early risk assessment, and the majority of the patients, they come in the second and the third trimester, and there are barely any visit in the first trimester pregnancy, and the action used to be taken as reactive rather than the predictive on predictive basis, and when the complications that develop, then the actions used to be taken, and there was no early risk stratification in the conventional model. Now, according to the inverted pyramid model of antenatal care, which is the latest approach, in which the earlier the used to be earlier there were too many antenatal visits, and there is load on the already on the burden of the antenatal care services. Now we stratify the patient at 12 weeks at the in the first trimester, and accordingly we label the patient as low risk at the or the high risk, and those patients which are at low risk, they are asked to come at 20 weeks for the target scan, and then later in the pregnancy they come at 37, and then they come for the delivery. But if the patients are certified as the high risk, then we keep the patient under the surveillance from 12 to 34 weeks of pregnancy, and accordingly we act as a preventive on the surveillance basis. And this concept of the inverted pyramid was proposed by Carpros Nicolaides, and the core principle of this is the maximal screening and the risk stratification in the first trimester, and then we follow on the individualized approach. So this inverted pyramid model helps in the early prediction of the high risk factors, and then we take the preventive measures, and then we do the personalized care according to the high risk stratification of the patients. So it helps in the prediction, prevention, and the early diagnosis, and the proactive management of the above complications like preeclampsia, ICR, preterm birth, spontaneous abortion, and the aneuploidies. So the aims and objectives of the first trimester screening. First trimester screening, that is the inverted pyramid approach, is to screen for the aneuploidies like trisomy 21, 18, and 13, which are the main causes of spontaneous abortions, stillbirth, and neonatal mortality, and trisomy 21 Down syndrome babies which born as they have mental retardation and many health problems in the future. And also this approach helps in the screening of developing preeclampsia, and likelihood of developing FGR can also be screened. And we can assess the first assessment of the length of the cervix with in this approach. And there are many anomalies which can be ruled out in the very first trimester scan. So what are the components of first trimester assessment? This assessment is done at 11 to 13 0.6 weeks, and we first take the maternal history, and then we score according to the risk factors. Then we measure the mean arterial pressure, which is the systolic pressure plus twice the diastolic pressure divided by 3. Then we take the uterine artery Doppler measurement on ultrasound and also measure the nuchal transvalency and biochemical markers like PAPPA, pre-beta HCG, and placental growth factors can be measured, and they are the components of the first trimester screening in this inverted pyramid approach. So what are the things we look in the first trimester scan? We look for the viability, we look for the gestation, we date the pregnancy and calculate the gestational age, number of fetuses. We can see here whether the pregnancy is single or twin pregnancy. Then uterus and adnexa can be seen. And then we screen for the aneuploidy in the form of nuchal transvalency. Nuchal transvalency is measured between when the CRL is between 45 to 84 millimeter. And if it is more than 2.7, then it is labeled as abnormal, and presence or absence of nasal bone is seen. There are additional biophysical markers can be seen like A-wave reversal in the ductus venosus and tricuspid regurgitation. Then there are certain anomalies which can be seen in the first trimester scan, like neurotube defects, like abdominal wall defects can be seen, and we measure the uterine artery pulsatility index, and if it is more than 95 percentile, we label the patient as having high risk. So these are the anomalies which can be seen in the first trimester scan, like neurotube defects like anencephaly, holoprosencephaly, then abdominal wall defects like amphiloceal and gastritis, megacystitis. Then we can also see for the presence of cleft palate in this. So sensitivity of first trimester scan in detection of structural anomalies is 37.5% and 91.3% for linear anomalies. And 3D and 4D ultrasound has moved the prenatal diagnosis of many anomalies from second to the first trimester. So first trimester scan can rule out many structural anomalies before our target scan. Now, after the aneuploidy screening, like this double marker test and nuchal transvalency and uterine artery Doppler, we can also screen for the first time screening of the preeclampsia. In this, we combine certain factors to screen for the preeclampsia, like maternal risk factors, mean arterial pressure, uterine artery pulsatility index, then serum placental growth factors, and these factors, these risk factors, can be put in the risk calculators on the online. Then we calculate the risk, and if it comes at 1 in 100 or more, then it is considered, the patient is considered as high risk for the development of preeclampsia. Now, what are the various maternal risk factors according to the ASUG and NICE guidelines? So, any of the risk factors in the list in the ASUG, and any of the, if the high risk factors like previous history of hypertension, then any medical disorder like renal disease, autoimmune disease, chronic hypertension, they are considered as high risk factors. And moderate risk factors like first pregnancy, then the advanced maternal age, body mass index is more than family history, they are considered moderate risk factors. And any of the one high risk factor or two or more moderate risk factors, they are considered significant. And in addition to the risk factors, we have biochemical markers like this placental growth factor, which is reduced in case of preeclampsia patients who are destined to develop preeclampsia. And PAPP is also low, less than 0.4 MOM is considered significant for the development of this. There are certain other factors also, but they are not yet empaneled in this screening. So So we combine these factors and then we calculate the risk. The maximum 100% sensitivity is seen when we combine maternal risk factors, placental growth factor, mean arterial pressure, and uterine artery pulsatility index. In combination, the sensitivity comes to 100% detection and the prediction of preeclampsia. But in the lower resource settings, where we don't have sonologists to measure the uterine artery pulsatility index and not a facility for biochemical tests like placental growth factor, we can go for risk stratification by maternal risk factor characteristics and mean arterial pressure collaboration, which will give the detection rate of 65% for the prediction of preeclampsia. Now, what is the advantage of doing this risk stratification is that we can stratify the patient and identify the high-risk women, and those women whose risk is comes at high, we can start these patients on aspirin 150 milligram every night from 11 to 14 weeks until 36 weeks of gestation. And it is seen that by starting aspirin in the first trimester, there is significant reduction of the preterm preeclampsia, and there is no increase in the adverse effects. When we compare this with the second, this is scaling the second trimester, the first trimester scaling gives good results in the prevention of preterm preeclampsia as compared to the second trimester. So we certify this by preeclampsia. Now we come to the FGR prediction. Again, in the FGR prediction, we have to evaluate the patient and ask for the risk factors and see for the maternal characteristics, behavioral characteristics, and medical disorder history. And we can also measure the biochemical markers like PAPPA, placental growth factor, and we also see the uterine artery pulsatility index in the on the ultrasonography. And it is seen that most of the factors which are predictor of preeclampsia, they overlap with the FGR prediction also, like placental growth factors and PAPPA and high UTPI. They also, and the maternal characteristics which are found to be high risk in this patient are the advanced maternal age, then low BMI, previous history of FGR, low socioeconomic history, and smoking, alcoholism, and medical history of medical disorders like chronic hypertension, diabetes, collagen vascular disorder, heart disease, lung disease. So all these maternal diseases and characteristics, they are the high risk factors for developing the FGR, and most of these characteristics they overlap with the preeclampsia also. So by combining the uterine artery pulsatility index with the low PAPPA, which we see in the aneuploidy screening also, and markers like low placental growth factors and maternal characteristics, we can predict the early FGR prediction. And if the patient is at risk of developing preeclampsia or placental dysfunction, we can start with the aspirin. There is no other preventive therapy in FGR. We can only do the surveillance in these patients. But if the patient is also coming in the group of high risk of preeclampsia development or the placental dysfunction, we can start with the same dose of 150 milligram in these patients also from 11 to 14 weeks up to 36 weeks. And we have to keep this patient under closest surveillance and timely Doppler follow and timing of delivery according to the Doppler parameters. So the inverted pyramid approach, it stratifies our patients into low risk and high risk, and depending upon that, we schedule our visits of the patients and then surveillance of the patient depending upon the risk stratification, and accordingly we plan the delivery of the patient. So if we compare the traditional and the inverted model has come up with the advantages and with the greater risk stratification and proactive management with the early prediction, prevention, and surveillance of the patients with good outcome. The benefits are reduced preterm preeclampsia, improved FGI detection, and there's better patient counseling with cost-effective on the long-term basis, and we optimize our resource allocation also. The challenges which we face in this implementation of the pyramid are the cost we have to bear. It depends upon the resources, and we need trained photographers to measure the all these parameters by physical parameters and Doppler standardization, and the access in those settings remains a challenge for us. But on history basis, on measurement of the basic characteristics, blood pressure, we can analyze and we can predict, and we can help the patient in a good way. Okay, and patient compliance is also good. So applicability in the those limited settings, or we can do the getting scan and we can measure we can MAP, and if the technology is available, we measure the Eastern RC Doppler, and we can start with the targeted aspirin in these patients, depending upon the risk score. So it can help us in the medical legal perspective also by early documentation of risk, and we have to keep our clear counseling records, then protocol-based aspirin use, and we have to standardize the screening, which will reduce our litigation problems. So future directions in the inverted approach are we can take the help of artificial intelligence, and which will help us in the creating the predictive models for the risk stratification, and we can universalize the placental growth factor screening, because it is reduced in both in FGR and preeclamptic patients, and we can also integrate the molecular level genomics to stratify to find the risk in development of these patients who are at risk, and then remote monitoring in the high risk pregnancy, that we develop certain gadgets that we from the remote patient remains away, and then we can detect the maternal fetal surveillance from a farther place and come to know what is going away with the patient. So with this, I conclude, and I thanks. The key take-home messages are the pregnancy complications. They usually begin early, so we have to detect and predict early. So it's a first trimester is the critical window for all these complications, and by this prediction we can enable our preventive methods, and we can put on and start with the preventive therapy. And aspirin, as per trials, it works well, and it has reduced the incidence of complications and morbidity and mortality in these patients of early preeclampsia development. And our antenatal care should be personalized as per the risk score, and so that the patients who deserve good surveillance, we can give them according to their risk stratification. And the future of ANC, the antenatal care, is predictive, preventive, and precision-based, and which is the basic principle of inverted pyramid approach. Thank you for patient hearing.
Thank you so much, sir. Now I would request my chairpersons, Dr. Parik ma'am, Dr. Renu ma'am, and Dr. Bharti ma'am, for any expert comments. Parik ma'am, you are muted. Kindly unmute, ma'am.
Yeah. Good evening, everyone. That was really a thought-provoking presentation, Dr. Dinesh. And thank you so much for sharing your insight on inverted pyramid approach to antenatal care. So approach should always be right at the right time and for the right one. So it is very important to target high-risk pregnancies, but you should not ghost, low-risk pregnancies. They should be given full support. And this is definitely going to optimize the care and outcome of the pregnancy. Thank you very much.
Thank you.
Good evening to all the dignitaries and my co-chairpersons. And congratulations, Dr. Dinesh, for this thoughtful lecture. I would like to add that, as you have rightly said, that this predictive model, it is better as compared to this traditional model which we are using, which is the reactive one. And in this, the first trimester visit is the most important visit. Earlier, we are up till now, it is just taken as a registration visit. Patient comes to us for registration, but actually this is the most important visit in which we can screen the patient, we can stratify, and we can plan the further course of pregnancy. But bottleneck is that many of our patients, because of social reasons, and many patients in the rural setups, they don't come to us in the first trimester. They come late in their pregnancy. And so this first trimester visit, which is so important, in this we are not able to do a risk stratification. So awareness is the key here. We should make the patients aware that they should, in spite of their social circumstances or other reasons, they should come to us in the first trimester. And also, the ultrasonologist, it is not available in many areas. There is an ultrasonologist with some course or degree, so they are not able to do ND-NP scan and all these things. They are just doing the viability scans. So that is also a problem. But otherwise, in the tertiary care centers and other in institutes, this is the best approach to follow. Thank you.
Thank you to our chairpersons.
Lynn, I need to congratulate my team. You all have been associated with me. I have been associated with you in some or the other way. And it looks so, it is for me such an honor and such a pleasure to see all of you doing so good in your field.
Thank you.
So happy, Dinesh, for you and all the respected chairperson. Now I have to see respected chairpersons,
Good evening, ma'am.
for
We are
giving your
always your
valuable,
students, ma'am.
no, valuable student, valuable inputs. And when, the students, they go higher and higher, one feels so good. One feels so good.
Thank you, ma'am. Thank you so much.
Thank you.
Bharti has come. Bharti has joined.
Ma'am,
So I think it is a high time I also say hello to everyone.
Yeah, Ragini, I was just calling you out. Give your message.
No,
We
I
were
joined
waiting
literally
for
because
you.
Namaste, ma'am.
yeah, it's very hectic. We are coming from a Delhi Menopause Society, CME.
Yeah.
So nice to see that show is going on.
मैंने बता दिया था डॉक्टर रागिनी, मैंने सबको बता दिया था कि हमने पकड़ कर रखा था मैडम को दिल्ली में.
इसने छुट्टी नहीं दी थी तुमको.
So the thing is that show should go on. किसी के लिए रुकना नहीं चाहिए. And thank you. जम्मू तो खैर बहुत ही स्पेशल है ये. But एक चीज मैं यहाँ कहना चाहूंगी, मतलब somehow it's totally inverted model. Nowadays people are talking about a Damru model when they're starting again.
That's what I was.
And again in the last 2 months it should be again on the broader base. That total inverted has changed, and I think it is really necessary, because what happened after in the 8 month and the 9 month, it is going to be in a very long way. I think the Damru model is better than the inverted model.
Can I add? Can I add? Ragini, can I add?
Madam, this is your platform.
I just wanted to say, with the traditional model, the lady has to come 13-14 times. for every woman has to call. But with this inverted pyramid, you are going to segregate the patients who are high risk, right? So the other people will be this in the streamline, and these people will have special care who have a risk factor. Most of the times, all the things that even inverted pyramid start with 13 weeks. Right, with gestational, if it is there, the life is there, you can have it in the platform if the facilities are there. And the third thing is that for the successful and healthy pregnancy, it is not only the antenatal part, it is the prenatal and the postnatal. They are now being added at the first floor, second floor, and third floor. So all these things have to be also added, because from the before the person becomes pregnant, you can stratify that she may be a high-risk patient. If the patient is very obese, if the patient's BMI is very high, if the patient has got some NCDs, right? So they are segregated before, and if they have some genetic factor there from the very beginning sent to the fetal medicine person, so that they can be counseled, the things can be streamlined, and they get pregnant, and then the antenatal care is taken. And in the postnatal period also, they are being good care has to be taken of the patient as well as the fetus. So nowadays, the inverted pyramid has also been expanded to the pre-pregnancy and post-pregnancy. So this is the things that I would like to add. Very, very, very enlightening lecture, Dr. Dinesh, and congratulations to you.
Thank you, Dr. Ragini, for the thought and for creating this, NIGF forum. All the people have become so active, and it is a learning and updating. It is a learning and updating.
The science is always changing every moment.
True.
Thank you. We should continue.
Thank you so much, ma'am. Ma'am, indeed, we are privileged to have Ragini ma'am with us. So, ma'am, if you could just deliver your presidential address also, ma'am. Yeah, we were waiting actually.
Yeah.
Good morning, Ragini ma'am.
Unmute.
Good evening.
So now I think I am unmuted.
Yes, ma'am.
Yeah. Very good evening to one and all. And Jammu has already done the conclave. They know all about what is an IGF and what is our mission and vision. And Dr. Sudha at the helm of the affair, I think there's nothing more to say than that this particular program under academic wing, we want more and more and more. Because it is academic wing, it is not the state program. So my expectation is too much from this academic wing program. We have all professors only there. I try to put everyone who is in the teaching faculty, not the private practitioner like me. So let's see what new you are going
teachers
to...
of teachers.
You are more than...
You are teacher of teachers, ma'am.
Yeah.
No. What new people are going to give in under the academic wing than just a webinar. So, but it is very nice what Dr. Dinesh has presented, and I am happy that to see a new person, a new face to present. That is our main vision in the NIGF. Everybody should get the platform to speak. Thank you so much. Thank you.
Thank you so much, ma'am. So now we move on to the second part of our session, that is the panel discussion. So we'll be talking about the obstetrical ultrasounds. And as we know that the obstetric ultrasound has evolved from primarily just a dating scan to a powerful modality that influences the diagnosis, the management, the timing of delivery, and even the fetal therapy. So I welcome our chairpersons for this panel discussion. We have with us Dr. Meeta Gupta ma'am. Ma'am is Professor Head and Dean Academics at AIIMS Vijaypur, Jammu. And also ma'am is the President NIGF Jammu Chapter. We welcome you, ma'am. We also welcome Dr. Kavita Bhatti ma'am. Ma'am is Professor and Head, Department of Obs and Gynae, CMC Ludhiana. And Dr. Shikha ma'am. Ma'am is Professor, Institute of Medical Sciences, Banaras Hindu University. We welcome all our chairpersons and also all our panelists. So we have the panel discussion on the top 5 ultrasounds in pregnancy.
Can I just interrupt? You experts also has to be taken their names, and if Navneet is there, can we have her inputs also in the lab?
Sure, ma'am. Dr. Navneet, ma'am, if you are there, ma'am, can we have your expert inputs, ma'am?
नवनीत मैम नहीं है sir.
Okay, then this time Meeta and Kavita, they are experts now.
Ji, ma'am.
Okay. Take their name also.
Yes, ma'am. I welcome Dr. Meeta, ma'am. And
Okay.
Ma'am, yes, ma'am.
Ma'am, Manju ma'am, she welcome. Namaste, ma'am.
Namaste, beta. God bless you.
जी मैम.
मुझे लगा या मैंने सुना नहीं कि
नहीं मैम, मैंने बोला था. So the ma'am, good evening. Thank you so much for joining, ma'am. Ragini ma'am, thank you so much. It's always an honor. I'm good, ma'am. Thank you so much.
So good to see you. So good to see you. And I tell you, Meeta is so busy, so busy. Along with academics, she is doing the administrative job also. ये इसने एम्स संभाल लिया है पूरा.
Yeah.
So we are proud of you, Meeta.
Thank you so much, ma'am. Mala ma'am, good evening, ma'am.
Carry on.
So today we are going to have the panel discussion on top 5 ultrasounds in pregnancy. And I welcome our panelists today, Dr. Saima Sadiq ma'am. Ma'am is consultant at SNGS Hospital, Government Medical College, Jammu. Dr. Suksham Sharma ma'am. Ma'am is consultant at Sri Mata Vaishno Devi Narayana Hospital. Dr. Tarini Singh. Ma'am is consultant at Government Hospital, Sarwal. Dr. Vishakha Gupta. She is assistant professor at AIIMS Vijaypur, Jammu, and also a fetal medicine expert. And Dr. Surekha Thakur. She is consultant at KD Multi-Speciality Hospital, and she is again a fetal medicine expert. So, beginning with the panel, I would like to start off with a very basic question, that is, which are the top 5 ultrasounds that we usually do in pregnancy? So I would like to ask Dr. Saima ma'am.
Yes. So we basically start with the early fetal scan, which is the scan for viability as well as the dating as well. Then next we go to the NTNB at the end of the first trimester. After that, we have the anomaly scan at around 18 to 20 weeks. And then in the third trimester, we have the growth scans and the Doppler in the end. Growth scan would vary from 28 to 32, depending how much we have the radiologist and all. We can do single, or depending upon the risk of the pregnancy, we can go for serial scans 3 to 4 weekly.
Yes, ma'am. Very rightly said, ma'am. So next we have case-based discussions. So starting with the case 1. So this is a 35 years old female. She's gravida to para 1, came to the antenatal clinic with the sonography report saying twin pregnancy of 8 weeks and 2 days. So is the report adequate? I would like to ask Dr. Suksham ma'am that what all are the parameters that we need to look out for on the early pregnancy and the fetal viability scan?
Good evening, respected seniors. Thank you, Dr. Hari. To the it was an 8 weeks pregnancy. So it was an early pregnancy scan, a fetal viability scan. So apart from the gestational, other parameters which are important to look in this fetal viability scan include, one is the CRL, which is measured in this earliest scan, is the best parameter for dating the pregnancy. So in patients with irregular periods or patients with wrong history, so CRL taken in the earliest scan is a very strong predictor of to date the pregnancy. First. Second is for the fetal viability. Now the fetal viability, to look for it, the gestational sac, the yolk sac, the pole, and the fat. So the measurements of the gestational sac, the look of the gestational sac, it should be a round, well-defined sac. So these parameters, the gestational sac, yolk sac, and fetal sac, These all parameters should have been mentioned in the previous scan. So it was just a twin pregnancy, 8 weeks, but the cardiac activity wasn't mentioned. That is another important parameter which should be mentioned. And the type of, how is the sac looking? Is the fetal pole there, embryo there? What is the CRL? What is the fetal heart rate? Also, though the early scan show 90 to 100 fetal heart, but these important parameters should be mentioned in the earliest scan. And along with this, another important two important other parameters which I think early pregnancy scan should be able to tell us is about the adnexa. See, any adnexal pathologies, any ovarian masses are most commonly detected at the earliest. Earliest scans give us a better picture of those adnexal masses. Any other structural anomalies in the uterus, and the status of the cervix. So I think along with that, these are the parameters should also be mentioned.
Yes, thank you, ma'am. So as very rightly said, so we need to look out for the location of the pregnancy, whether it is intrauterine, extrauterine, the number of fetuses, what is the gestational sac like, what is the yolk sac like, the fetal pole, the fetal cardiac activity, any subchorionic hematoma, the status of the uterus and the adnexa. And for the twin pregnancy, the chorionicity is again very important. So for the chorionicity, I would like to ask Dr. Surekha Thakur, who is a fetal medicine expert and expert in doing ultrasounds also. So ma'am, how can we determine the chorionicity, and what is the lambda sign, what is the T sign, like how will we differentiate between the monochorionic, dichorionic twins?
Thank you, Halgi ma'am, and I would like to wish all the seniors present here. So as ma'am has already explained that what are the other parameters which we should see in such cases which are done in the early first trimester, and chorionicity in the twin pregnancy is one of the very important parameter, because this is the only determinant of the outcome of the pregnancy in the twin pregnancy. So, and the best time to see for the chorionicity is between the 6 to 9 weeks period of gestation, and definitely before 14 weeks of gestation, because in the second trimester or in the third trimester, the chorionicity will be determined suboptimally and it would not be that much reliable. And to see for the chorionicity, we should see the number of the gestational sac, number of the yolk sac, and we should see on the intertwin membranes, if especially done after 10 weeks of gestation, what is the thickness. If it is less than 2 millimeters, it is seen mostly in the monochorionic twins, and if it is more than 2 millimeters, that is seen in the dichorionic twins. And then we see on the number of the placentas. Sometimes we see 2 placentas separately, and sometimes they can be fused. And in such cases, we see for different signs like lambda sign or the T sign. In the lambda sign, we can see that there is a projection of placental tissue between the intertwin membrane at the placental insertion, and that is a sign of the dichorionicity. Whereas in case of the monochorionic twins, both the placentas, they fuse at 90 degrees, and there would be no placental tissue between the intertwin membranes, and it will be visible like a T sign, because it resembles the T letter, and that is a sign of the monochorionic twin pregnancy.
Okay. Thank you so much, Dr. Surekha. So now, if this twin pregnancy is carried forward, so maybe we can encounter some certain types of complications of the twin pregnancy. So one such very important complication is twin-to-twin transfusion syndrome. So I would like to ask Dr. Kalani ma'am that what are the early signs of twin-to-twin transfusion syndrome, because they can be picked up on the ultrasound, which we are going to talk about today. So can you just enumerate some few signs of early TTTS?
Yeah, good evening, all the respected seniors, and hello, Harleen. So like Surekha already mentioned that if the T sign is present, it is usually a monochorionic placenta, and the most common complication which in such pregnancies occur, that is twin-to-twin transfusion syndrome. It occurs in approximately 15 to 20% of such patients. The earliest sign to look for in such patients is the disparity in the amniotic fluid volume in two sacs. So what we see is that in one, which is the donor twin, the amniotic fluid volume is less, with the single largest pocket being less than 2 centimeters. And in the recipient twin, which is getting more of blood towards it, the single largest pocket becomes more than 8 centimeters if it's less than 20 weeks, and more than 10 centimeters if it's after 20 weeks. And this fluid imbalance between the two is usually the most earliest detectable sign. Then there are other signs also, like we see bladder difference in the donor twin. The bladder will get absent eventually. And then we have the reduced urine production because of reduced urine production. The recipient twin will have an enlarged bladder and overfilled bladder. Also, also what we see is the growth discordant in these twins. So there's a disparity of when do we say that they are growth discordant? When there's a difference of at least 25% or 20% in the estimated fetal weight between the two. And then there come the Doppler changes, which is the blood flow in the umbilical artery, the ductus venosus, the umbilical vein. And these, as the disease progresses, they all get worsening with time, which we see the changes. Now we are coming to the Quintero staging, which this is the staging that we use in twin-to-twin transfusion syndrome to see that at what stage is our fetus is present. That is a stage 1, again, is the earliest sign, as we said, that it is a fluid imbalance. So the fluid, there will be disparity in the amniotic fluid index. In one, there will be less, that is less than 2, single largest pocket, and the other twin will have more, that is more than 8 centimeters. But the donor bladder will be visible. In stage 2, the donor bladder won't be visible, and there will be fluid imbalance persistent. Then comes the stage 3, then the Doppler parameters will get absent or will get abnormal. That is, there will be absent or reversal of flow in the twin 1 or both the twins. And then finally in stage 4, the hydrops fetalis will develop. That is, there is excess of fluid in the pleural cavity, there'll be subcutaneous edema, there'll be fluid all over in the recipient twin. And finally, there'll be demise of the fetal demise. That is the stage 5th, which is the last stage and it is not applicable for any sort of treatment.
Okay, thank you so much, ma'am. So we have the different types of the twin pregnancies, and on ultrasonography, once we have made the diagnosis and we know that what kind of twin pregnancy it will be, so it will help us in determining the complications and determining what time we need to deliver these twin pregnancies. So as I already mentioned in the beginning, that scans nowadays not only help us in diagnosis, but also determine the management protocols. So I would like to ask Dr. Saima that what will be the timing of delivery for the different twin pregnancies, different types of twins?
So, Dr. Herleen, again, it will depend on what type of twins we are dealing with, depending upon their chorionicity and amnionicity. So, suppose we are dealing with the dichorionic, diamniotic type of twins. So, and if there is no associated complications like preeclampsia or Doppler changes, FGR, it's an uncomplicated twin. So we can deliver them, we can take them up till 38 weeks. So then coming next to the monochorionic diamniotic twins, again, because they are sharing the placenta, so they are a little at a higher risk. So for these twins, again, if there are no complications associated, we can go till 36 to 37 weeks. And if I talk about the monoamniotic and monochorionic twins, and they are at the highest risk because of the cord entanglement problems. These twins, they need to be, in fact, admitted at around 28-30 weeks, and we need to terminate them at around 32 to 34 weeks, of course, after giving steroids. And while we are dealing with these twins, we have to keep in mind what are the other associated high risk involved with these kind of twins.
Okay, ma'am. Thank you so much. Now coming to the case 2. So this is a first trimester screening scan. A 32 years old lady at 12 weeks, 4 weeks, 12 weeks, 4 days gestational age goes for an NT scan, and the NT measurement is 3.8 millimeters. So how significant is the NT measurement? Dr. Saima, if you could take this question as well.
Yes. So NT, nowadays, it's a very important thing that we all need to do. It's basically, it is going to tell us about, it's a marker of aneuploidy and any other structural anomaly or any genetic defect that we are suspecting in the pregnancy. So what basically NT is, it's done around 11 to 13 weeks and 6 days. There is a set criteria which has been laid down by the Fetal Medicine Foundation, who will do the scan and what is the prerequisites, how we do the scan. So ideally, there is a predetermined CRL on which it is to be done. Like it's from the crown rump length should be from 45 mm to 84 mm. Then you have to take a mid sagittal section. The screen should cover the head, and the upper thorax should cover 2/3 of the screen of this machine. Then the fetus has to be in the neutral position, and then you have to measure the translucent space, the clear space, inner to inner. Calipers have to be placed inner to inner, and the person who does has to be certified by the fetal medicine foundation, and it has to be, they need to revise their this certification periodically. So it's very important because ultimately what measurement comes, it is interpreted as percentiles. If it is more than 95th percentile for that particular CRL, then it becomes significant. We need to do further testing.
Okay,
And
ma'am.
it is a marker not only for your aneuploidies, but also other things like your congenital heart diseases, skeletal dysplasias, other single gene disorders, apart from your routine, this Downs and Patau's and Turner syndrome.
Okay, ma'am. Thank you so much. I would like to ask Dr. Vishakha that what are the additional ultrasound markers which should be assessed at the first trimester screening?
Good evening, everyone. Thank you, Harleen ma'am. In addition to the nuchal translucency, we usually go step by step. We have to check for the viability, check for the fetal heart rate, because it is also the indicator for some of the chromosomal defects, like it is increased in trisomy 13, trisomy 21, and Turner syndrome, while it is decreased in trisomy 18 and triploides. Usually we take fetal heart rate from 120 to 160 in the NT scan as normal. Then we have to go for the crown rump length. Usually crown rump length is done before taking the NT measurement, because there is a 45 to 84 mm rule, which Dr. Saima has rightly said. And after that, we have to check for the number of fetuses. If it is a multiple gestation, then we have to look for define the chorionicity and the amnionicity. And then in the same mid-sagittal plane, we have to look for the nasal bone. If it is hypoplastic or it is absent, then we have to recheck again at the 15 weeks, because sometimes there can be delayed ossification also. Usually nasal bones ossify at around 15 weeks. So we have to call the patient again for a relook scan for the ossification of the nasal bone. Then we have to go for the abdomen. In the abdomen, we have to look for the ductus venosus Doppler. If the ductus venosus usually has S, D, and A waveform. If the A wave is absent or there is a reversal, it indicates there is a 80% risk of trisomy 21. But in 1% of the fetuses, they said 1% of such fetuses where A wave is reversed, they can be euploid also. Then again, if it is isolated, we have to call them at 16 weeks, recheck again the ductus venosus A waveform. If it is normal, then we have to call her for the fetal echo also. For the tricuspid, in the four chamber view of the heart, we have to look for the tricuspid regurgitation. Usually the waveform is as E, A, and S waveform, and in the regurgitation, the S waveform is inverted, and which goes beyond 60 centimeters per second. So it is also the risk of trisomy 21 is seen if in 65% of the fetuses, and in case of isolated tricuspid regurgitation, then it is less likely that there is some aneuploidy. Then we have to again call her at 16 weeks. If it normalizes or resolves, then there is no need of doing fetal echo, and it reflects the right-sided heart failure. Other things that we can do after these markers is the early anatomy survey. We can look for the presence of bladder. We can look for the presence of stomach. If the length of the bladder, longitudinal length of the bladder is more than 7 mm, it is suggestive of megacystis. We can look for exomphalos. We can look for gastroschisis. We can look for acrania or holoprosencephaly. We can look for the body limb deformities or limb defects, bilateral short femur, single umbilical artery. We can look for the heart defects like hypoplastic left heart syndrome or hypoplastic right heart syndrome. And we can look for the premaxillary triangle for the maxillary ossification. Apart from this, we can also do the maternal screening for preeclampsia, or for the fetal growth restriction also we do a uterine artery pulsatility index. Usually it is the cutoff, it is also calculated in centiles. If it is more than 95 centile, it is an indicator of preeclampsia or fetal growth restriction, and such fetuses have to be monitored every 4 weekly from 28 weeks. And there are some new modalities also which we can do, which have a future, like ophthalmic artery Doppler, which is a single like this maternal screening for preeclampsia, which can replace the combined screening of doing with mean arterial pressure or uterine artery PI and PLGF. So it has a future, and just one single value of OAD can guide for whom we have to start with the ecosprin or low dose aspirin dose.
Okay, thank you, Dr. Vishaka, for the in-depth view of what all we need to look out in the first trimester screening. So, Sukshma ma'am, what is the role of combined screening versus NIPT?
Now we need to know before answering this, like combined screening is a combination of NT with dual markers and the maternal age. So combining these three, the detection rate is approximately around 85%. And however, the other soft tissue markers, which Dr. Vishaka clearly explained, if we add them, the sensitivity increases around 93%. So when coming on to NIPT, though the sensitivity of NIPT in detecting trisomies is too high, reaching up to 99%, with a false positive rate of 1%. But we need to keep one thing in mind, that both these investigations are screening tests. None of them are confirmatory or diagnostic. So while counting the patient attendant regarding the next step which is to be taken, we need to inform them that NIPT is also not confirmatory. In cases where NT is straight away more than 3.5 high risk, in those cases NIPT clearly has no role at all. In those cases, direct invasive testing is what we recommend. In cases where NT is between 3 to 3.5, again, then this is a topic of discussion. Like, we need to tell them that NIPT can detect slightly higher than this combined screening, but then confirmation is again with. So coming them the very, very dicey situation, what to go ahead with. But keeping in view this fact that if the NT is clearly high, more than 3.5, not going towards NIPT at all, direct invasive testing. If it is between 3 or 3.5, we need to counsel them. We need to give them both the options of NIPT as well as the invasive testing, because both of them are screening. So thank you.
Very rightly said. So both of them, they are screening tests. So that is very important thing, and that we need to tell the patients, and we need to counsel them, and we need to clearly tell them that if they want to go for some diagnosis, so we need to do the invasive testing. So now our fetal medicine experts, I think Dr. Vishaka and Dr. Surekha, are routinely doing these invasive testing. So when to offer the invasive testing, and whether we should go for CVS or we need to go for an amniocentesis. So if Dr. Vishaka, if you could take up this question.
Yes, ma'am. In the first trimester screening, if we have found that the NT value is more than 95 centile, or if the cutoff is, if the value is more than 3.5 mm, then we have to go for the invasive testing. Now it depends upon the gestational age at what the patient has presented to you. If the patient has come in less than 13 plus 6 weeks, then we can offer them chromosomal microarray also. But if we have a doubt of trisomy 21, which can be due to some mosaics also, then it is better to go for amniocentesis, because there is a rare case scenario in which we can find, we can have a diagnosis of confined placental mosaicism, which can be seen with the chromosomal microarray. Then again, we have to call that patient for amniocentesis to rule out that confined placental mosaicism. So in those cases, we have to go straight away for the amniocentesis by counseling the patient properly. And also what genetic test we have to offer in case we have found increased NT is depends upon the value of the NT also. If the value of NT is more than 3.5 mm, then it is better to go for chromosomal microarray, because it has a diagnostic yield of 6 times more than the karyotyping. And if the NT value is more than 5 mm, then we have to go for the chromosomal microarray, plus we have to do a molecular testing for the rhazopathies also. Rhazopathies are mainly Noonan syndromes, Costello syndrome, or neurofibromatosis. So we have to look for them also. In case the anti value is more than 3.5 mm, plus we have a ultrasound detected anomaly also, then again we have to go for chromosomal microarray and we have to look for the rhazopathies. And in case the anti value is more than 7 mm, then we have to go for a whole exome sequencing. So it was about the anti. In case our ultrasound is completely normal and we have ordered a first trimester screening with the dual marker, and we have found that in the report it is screen positive for trisomy 21 or 13 or 18, then again we have to offer for invasive testing in order to confirm the diagnosis. In case of trisomy 21, if the risk is more than 1:250, and in case of trisomy 13 and 18, if the risk is more than 1:100, then we have to counsel the parents for the invasive testing. And in case the parents have got done the NIPT, then also if NIPT is positive, then we have to go for a confirmatory diagnostic test, that is invasive testing. If there is some known case of genetic disorder in the family, or parents are having some genetic disorder, or in previous baby there was a genetic disorder, then also we can go for a invasive testing. In case of early diagnosis, we can choose for chromosomal microarray. And in case there is parents are carriers for thalassemia trait or sickle cell hemoglobinopathies or spinal muscular atrophies, then also we can go for chromosomal microarray in the early trimester. And in case our ultrasound has some structural abnormalities in the fetus, or there are some soft markers which have a high likelihood ratio for a chromosomal aneuploidies, then also we can offer invasive testing for such cases.
Okay. Thank you, Vishakha. So now we have another case. So we have a 27-year-old lady, and she is gravida 2, para 1, live 0, and she comes to us at 20 weeks of gestation with the anomaly scan, which is suggestive of an isolated echogenic intracardiac focus. So now, does this change our risk assessment, and should further genetic testing be advised for this soft marker of Down syndrome? Dr. Tarni, if you could take this question.
Yeah, so an isolated echogenic intracardiac focus is actually a very common finding which we see in our daily day-to-day basis. So we need to understand what is this. Actually, this is just calcium deposits which occur on the papillary muscle or the AV valves of the heart of the fetus. Now, if it is an isolated finding and we have no other soft markers associated with it or any other history, high-risk history of the patient, either she has had no other baby which is suffering from any aneuploidy or any other genetic history, persistent genetic history in the family of this patient, then nothing has to be done. This is an isolated finding. We have to counsel the patient that usually nothing has to be done. And if the patient says, no, we are apprehensive, we want to go further for any testing, then we can offer quadruple or any screening to them if earlier the patient has not been screened. But if this finding is associated with other soft markers on the ultrasound, as rightly said by Vishakha and Surekha, that other factors like ductus venosus, there are changes, or there is ventriculomegaly, there is present, or any other signs which are present, then definitely we have to go for further genetic testing, and then we have to evaluate the patient as a whole. Sometimes what happens is that instead of an isolated, there are echogenic foci which we see on the ultrasound also. In those cases also, there have been many studies done, and they found that they are also mostly benign, if not associated with any other soft markers. And sometimes if they feel that any other cardiac defect is present, then we can offer echocardiogram to such patients also. But that all depends upon the whole picture of the patient and seeing other risk factors also.
Yes, so very rightly said that just a single marker, that is a single intracardiac echogenic foci, we do not need to panic, and we do not need to straight away go for invasive testing. It can be just a benign normal variant which can be seen in many patients. So that is an important message that we need to know to us also and to spread to the patients also. So what are the other soft markers we can look out for, Dr. Surekha?
Yes, thank you, ma'am. As ma'am has rightly said that isolated echogenic cardiac focus has very less likelihood ratio for the aneuploidies. So if it is isolated, then we have to look for the other soft markers, which I think in this case we have done it. And the other soft markers which we should assess are like ventriculomegaly, choroid plexus cyst, thickness of the knuckle fold, and absent or hypoplastic nasal bone. Then in the thorax region, we can see for the apparent right subclavian artery, presence of echogenic cardiac focus. And then in the abdomen, we can see for the hydronephrosis or pyelinectasis. And then we can see for the echogenic bowel and short femur or humerus. And some other markers are also there, like single umbilical artery, sandal gap, or short ear length. So these markers should be assessed, and based upon that, we can calculate, based upon the likelihood ratio, we can recalculate the risk factor and then counsel the patient accordingly for the further testing.
Okay, thank you, ma'am. So, what are the indications for the fetal echo? Dr. Vishakha?
Yes, ma'am. For fetal echo, ma'am, if we have in the first trimester, if we have diagnosed any abnormal four-chamber view or like abnormal outflow tracts, or there is a ductus venosus A wave reversal which has not resolved, then we have to go for a fetal echo. Or in case of second trimester, which in which we are doing a cardiac screening with the 5 planes, if there is any abnormality other than the isolated echogenic foci, then we have to offer, we can go for fetal echo. Otherwise, if there was an increased nuchal translucency in the first trimester, it was more than 95th centile, then also we have done the invasive testing, but we have to go for fetal echo again at 22 to 24 weeks. If there was a presence of any extracardiac malformations like diaphragmatic hernia or falloceles, which are usually associated with some cardiac problems also, then we have to go for this fetal echo. In case we have found some arrhythmias, and in case of hydrops fetalis or in case there are any genetic abnormalities, or in case of twin pregnancies, mainly in monochorionic twin pregnancies, because there is high risk of having cardiac abnormalities in such cases. In case mother is having pre-existing diabetes, then also we have to go for a screening echocardiography for the fetus. If there is a family history of congenital heart disease in the parents or in the sibling, then also we have to go for fetal echocardiography. Autoimmune diseases such as SLE or Sjogren syndrome, where we have to look for the where there is a presence of anti-Ro and anti-La antibodies, which can affect the fetal heart and can cause arrhythmias. In case of IVF conception, or if there was a teratogenic exposure with the anti-epileptic drugs or retinoids or alcohol, or in such cases, we also order fetal echocardiography. In case mother had infection in the first trimester with rubella, then also we have to go for fetal echocardiography.
Okay, thank you so much, Vishakha. So now we come on to another case. So this is a 30-year-old lady, and on the ultrasound, we find that the estimated fetal weight, it is less than the 10th centile, and the umbilical artery Doppler shows PI value, which is more than 95th percentile, but forward end diastolic flow is present. So now what does this elevated uterine artery PI indicate? And is this placental insufficiency? Suksha ma'am, if you could take this question.
Yeah. Harleen, this was elevated umbilical artery?
Yes, ma'am.
Yeah. So we need to understand what is PI. Like PI is a ratio of the blood flow during systole and the blood flow during diastole. In normal circumstances, the blood flow remains normal, but in cases where there is placental vascular resistance, so in those conditions, the diastole flow gets affected first. So since the diastole flow gets affected, the flow decreases, and so the SD ratio increases. That is, the PI increases. So in this case, like if the PI is more than 95th percentile, so it clearly indicates that there is some sort of vascular resistance, placental vascular resistance. And so it is an early marker showing that placental insufficiency is setting in. So we need to keep this patient on proper surveillance because this showed that the diastolic flow is still forward, but we need to follow this patient to see on weekly Dopplers that whether, because this can further progress to an absent diastolic flow or a reverse diastolic flow. So presently, this PI more than 95 is indicating an early placental insufficiency, which requires further surveillance and follow-up.
Okay, ma'am. So, Dr. Surekha, if you could tell us that what is the sequence of deterioration, like how does that happen?
Yes, ma'am. Fetal growth restriction usually follows a predictable hemodynamic sequence, because as we know that there is increase in the resistance in the blood flow in the placenta, and the first thing which gets affected is the umbilical artery, and the change which we see in the umbilical artery is initially there is increase in the pulsatility index of the umbilical artery, and then when the resistance increases further, there would be reduced end diastolic blood flow, and which will eventually lead to the absent end diastolic flow, and then it will lead to the reversal of the end diastolic flow. So if this, then the second step which happens is that fetus starts to compromise and it starts to compensate, and there occurs the redistribution of the blood flow for the vital organ, that is called as the brain sparing effect, and which will with the help of the Dopplers in the medial cerebral artery, and we will see that there would be reduction in the pulsatility index of the medial cerebral artery, and there would be reduced cerebral placental ratio. And if the hypoxia persists, and then there would be cardiac decompensation of the fetus, and that will lead to the changes in the Doppler of the ductus venosus, and which will be seen in the form of the increased pulsatility index in the Doppler of the DV, or there would be absent or reversal of the A wave in the ductus venosus. And if further intervention not done, then it will eventually end up into the neurological damage would be there, and it will be evident in the form of the late decelerations, change in the variability, or in the changes in the CTG. And if no intervention not done, then it will eventually lead in the demise of the fetus.
Okay. So, depending upon these Doppler changes, Dr. Tarani, like how do we decide that when to deliver the patient with what kind of Doppler changes they are presenting to us with?
So for delivery, we have to see many things have to be taken into account. First, the Doppler changes that we are seeing, and also the period of gestation is very important. Now, if it's a early FGR, that is at 32 weeks and less period of gestation, so we need to see the Doppler changes at what stage it is. Either it will be umbilical artery or absent or end diastolic flow, then we have to consider delivery. And we can also look for the ductus venosus changes, where we have the specialized centers and radiologists available where they can actually see absent or reversal of flow in the ductus venosus. So what we do is that we counsel the patient, we give them steroid, and then we have to consider delivery in these cases. If there is reversal of flow that is in the ductus venosus, then there will be immediate delivery. Now, for the late onset FGR, that is after 36 weeks and approaching term, we have to see again the stage of Doppler changes. In these, we can wait. But if the brain sparing effect has occurred, then that becomes a sort of a gray zone for us. Then again, we have to counsel the patient, we give her steroid, and we see in these cases, there's a lot of role of continuous CTG monitoring that is important. If at any point there are persistent decelerations or any fetal heart rate changes, then we have to do immediate delivery. If the fetal heart rate is going normal and it is steady, then we can wait and we can see that how things go.
Okay. Thank you so much, Tarni ma'am. And with this, I think we come to the end of our panel discussion, where we have taken up scans from the first trimester, the second trimester, and the third trimester, and reflecting upon the importance of these scans and how they will help us in determining the management of the different patients. So with this, we end this panel discussion. If we have any comments from our chairpersons or the experts, I think Neeta ma'am had to join a very important meeting, so she is currently not with us. I would request Dr. Sudha ma'am or Dr. Manju ma'am, if you could please
Sudha ma'am is left.
Share some expert comments with us. Manju ma'am?
Dr. Kavita also is not there?
Ma'am, Kavita ma'am also I cannot see.
Okay. I am really very glad for how the panelists have answered the question which you put forward for them. I'm very happy that the panel has been done very nicely. That's all I can say. Congratulations, everyone.
Thank you.
Thank you so much, ma'am.
Thank you so much.
And yes, all the fetal medicine people
you,
are
ma'am.
really thankful to you for joining us. You have given such good inputs into our minds that if there, what is to be thought for. Thank you very much. Thank you very much, everyone.
Thank you so
Mala, would
much,
you like
ma'am.
to say something?
May I say, give a comment?
Yes, ma'am.
It has been an excellent learning evening. We had the choice of subject has been really good. And
Yes.
all the panelists had done a good justice to the topics and the points that has been picked up on the ultrasound. Day in and day out, we get patients who are having different entities, twins with their questions, and intracardiac echogenic focus. All these points, they come in our day-to-day practice. And as a clinician, as an obstetrician, we should be clear in our mind how to counsel the patient and when to refer them to a fetal medicine specialist. Because nowadays, patients are also very aware. They Google, they come, and they have many questions. And it's definitely our duty to allay their questions, answer their questions, and appropriately guide them when they need invasive test, when they need to go to a genetic specialist, when they need to go to a fetal medicine specialist, because at the end of the day, we want healthy mother and the healthy baby. We don't want to cut a sorry figure at the end of the pregnancy.
Yes.
And that's the demand of the day. Excellent topics, nicely chosen, well discussed, and I'm sure all the delegates will definitely benefit from today's scientific deliberation.
Thank you so much, ma'am.
Thank you so much.
Thank you, ma'am.
I think Ragini ma'am is also here. Ma'am.
Wow.
सच्ची बोलूं मैंने बहुत थोड़ा सुना है. I am in a prayer meeting.
Okay,
I was there, but I have listened very less. Whatever, but the heading I have seen, it is very important. I always say that today's whole obstetrics should be written under scanner. Without ultrasound, we are totally handicapped. That's why we are running a program also, obstetrics under scanner as a physical CME. And we have a mission also, a strategy to reduce the birth defect. So I hope whatever is discussed, it must be very, very wonderful.
Okay, ma'am. Thank you so much, ma'am. And now, before we close off, I would like to pose the vote of thanks for today's evening. And first and foremost, I would like to extend my gratitude to our chief patron, Dr. Sharda Jain, ma'am, although ma'am is not here with us today, but her blessings and her inspiration, that is always with us. Our sincere thanks to our president, ma'am, Dr. Ragini Agarwal, ma'am. Ma'am is always very dynamic, very motivating. We are indeed privileged to be working under you, ma'am. It is indeed a blessing. We are also deeply grateful to Dr. Manju, ma'am. And especially, I thank Manju, ma'am, for bearing with me, although she was after me in arranging this program, but sometimes...
You must be thinking कि मेरे पीछे पड़ गई.
No, ma'am. I was sometimes unable to do all the work on time, but somehow I think we managed.
Everything that ends well is good.
Yes, ma'am. So it was all your guidance, ma'am. Thank you so much. I again thank all the chairpersons who took our time from their busy schedule and they have joined us today. Most importantly, our speaker, Dr. Dinesh sir, he presented very nicely, and to all our panelists. And many of them, they are my friends. And I would like to thank and appreciate the efforts of Dr. Sudha ma'am, Dr. Meeta ma'am, and Dr. Parik ma'am, who always come forward and give chance to the youngsters. They want that all the new people and all the young people, they should come forward and they should join in so that they will participate more and more in the future events. So that is a very important thing that is there. And then again, Sonika ma'am, I don't know if she's here. She has helped us a lot. So a big thank you to Sonika ma'am also, to Mala ma'am, Dr. Ruby ma'am, and all the other dignitaries who have taken out time and they have joined us today. I thank them once again. And especially our NIGF Academic Wing. So the whole of the wing and the whole of the NIGF. And I thank all the audience who have joined us today. I'm sure that it must have been a good learning experience for you. Thank you so much.
Thank you, Harleen.
Another one announcement. Next 25th of March, we'll have the next session. But the next state. Maybe it is Punjab or Chandigarh. You will decide between them. And we are going to have it on 25th of March again.
Okay, ma'am.
So one more announcement. 18-19 July is the annual conference, and please try to come because it's the only time we can all meet together.
Sure.
It is in Chandigarh, not very far from Jammu also.
Yes.
Sure, ma'am.
It's in Chandigarh.
Sure, ma'am.
Okay. Bye.
Thank you so much.
Thank you.
Bye, everyone.
Thank
God
you.
bless you.
Bye. Thank